Good afternoon, everyone. My name is Rohit Mohan. I'm a pediatrician and Chief Medical Information Officer over at Venice Family Clinic, a community health center affiliated with UCLA Health in the Los Angeles area. And today I'll be talking to you all about serious illness finding tool, which is an AI algorithm that we're trying to take from a palliative care setting over to a community health setting. So the background of this project, I did my informatics fellowship over at Cedars-Sinai, and I worked with one of my mentors, Andrew Hudson, kind of doing various AI algorithm development, including for stuff like sepsis. And one of the tools that he was creating for the palliative care population was a tool called SIFT. So it's a clinical decision-making tool, like an AI algorithm that identifies seriously ill patients. And he first off created an LLM that could use vector embeddings based on a variety of medical texts. And then he fine-tuned it with over 18,000 data points from the EHR to really hone in on which of those patients are critically ill. And the type of data it uses includes a lot of different data points from the EMR, including clinical notes, medications, lab results, path results, procedural data, and radiology findings. So wide variety of data. So a lot of times with these algorithms, it's a little difficult to wrap your head around what it looks like and what it's doing under the hood. So I thought this schematic that his team had created was kind of helpful with some of that. So the left box, the blue box kind of talks about the data that was inputted to train the LLM. And then it chunks it into text, which then gives vector embeddings. And then it basically from there, it takes it and clusters a patient's risk and assigns risk scores based on nearest neighbor associations and their risk in various different subspecialty areas like cardiology, oncology risk, based on a wide variety of data. And the way that an end user interfaces with it is through prompting an LLM and kind of fine-tuning the output over time. And then after kind of going through the LLM, it'll give you a score between 0 and 100 to give you the mortality risk of the patient, functional decline, quality of life metrics, caregiver burden. So things that a palliative care doctor would be interested in. One thing that's very specific about this model that was a good fit for taking it to the community health setting that I liked was it focused on palliative care patients, which are patients that tend to be good to establish a baseline of an ill patient, given that they have a lot of end-of-care life discussions with a variety of specialists. So having those kind of note information, having those kind of lab results, all that information really gives you a well-rounded baseline of a patient who's ill and with particular detail in what type of area that they'd be ill in. So that was one thing that was really unique about SIFT that I liked, and which was why it was a good fit for this next phase of the study. And one thing they did was they fine-tuned it after many rounds and over 23,000 palliative care patients between 2016 and 2024. And then they took 24 clinicians of various subspecialties and took their, had them do chart review, look at individual patients on 200 charts, and then validate their output against SIFT's output while being blinded to it. And then this showed, that it was based on internal validation. They showed that the algorithm had a 90% sensitivity in picking up patients that may be seriously ill, 77% specificity in ruling out patients that aren't as sick, and 86% accuracy when comparing it to a clinical output. So this slide kind of talks about the inclusion criteria for that validation set. So this is actually the test set. So the slide actually I've mislabeled it, but it's basically all hospitalized patients from September through November 30th of 2023. A smaller subset of that initial training set became what they validated on. And one thing that's key to note to take away from the slide is that it's hospitalized patients who aren't critically ill, like in the ICU or in the ER, but just focused on patients who are sick but not critically ill. So the next piece of this project where I got more involved was, I was tasked at our health center to help find an algorithm that could potentially identify sick patients, given that for federally qualified health centers, we tend to be pretty resource strapped, and we're moving towards like value-based care models of payment, where we need to be able to identify our sickest patients in a much more systematic manner, and we don't have the resources to potentially provide resources to everyone in our system, without knowing who our sickest patients are, especially in what kinds of areas they need help in. So a model that could really cluster their risk into different areas would make a lot of sense for our health system. So what we were hoping for is taking this model and retraining it on community health patient data and democratizing it to make it more usable. And our health system is a good use case for this because Cedars-Sinai is primarily located in West Hollywood, Beverly Hills, a primarily affluent palliative care patient population. Isn't that generalizable? But at Venice Family Clinic, we're kind of a community health center that's been around for over 50 years. We have 3.2 million patients in our patient base, primarily underserved and a variety of minorities, and we cover 56 zip codes in the Los Angeles area. So if we could retrain it and pilot it in our system, I think it could benefit a lot of other systems and be kind of more usable by a variety of folks. So when this collaboration was kind of born is when I heard of the NIH Aim Ahead CDP grant, so applied earlier this year, and I'm trying to get funding to kind of take an OCHIN data set and then retrain it for the community health system. So for those of you who aren't in the informatics or EHR world, OCHIN Epic is a consortium of FQHC systems, community health systems, that are on a common instance of the Epic EMR, and they have a vast data set of like-minded community health systems that kind of have similar member populations, and they help end users with data extracts. So they'd have the kind of data and the volume you'd need to retrain a model like this. So we're hoping, I'm switching our system over to Epic later this year. So we're hoping during that implementation process we could potentially collaborate on OCHIN for some research. All right. Perfect. So yeah, this is kind of the project goals of the next phase of the project. So this initial phase was with called the Serious Illness Finding Tool over at Cedars-Sinai with the palliative health care population. The next phase, we're hoping to make the model shift over into the SHIFT model, which is focused on, we're going to call it the Standardized Health Initiative Focus Tool, more focused on the community health setting. So we're going to, based on the grant, we had to talk about 3 phases of the project, kind of retraining the model, then deploying it at one site or like one health system, and then building a consortium of others who can use the model as well. And so that's kind of the project goals over here. So retraining it. And then one thing we hope to do in step 3 is not only like retraining it and identifying patients, but potentially connecting them with resources or directing them to appropriate specialists or community resources to mitigate adverse health outcomes before they happen. And then eventually build a consortium where we would roll it out to other community health centers with similar patients. So going into what kind of data we may need. So SIFT was trained on a ton of data, and I don't know if we will be able to get as many 18,000 data points, but we hope to at least get, based on what I saw in the data dictionary for the OCHIN community health database, some of the basic things we could train things on. And there's going to be some new areas we hope to add into this data set. So not only encounter data, note data, demographics, diagnoses, immunizations, lab results, but the piece that's unique that we hope to add on is social determinant of health data, which tends to be a big focus now in the the healthcare world and the underserved population. And the OCHIN database has a lot of that. And for those of you who don't know what social determinants of health are, they're predictive measures or measures we collect from patients for adverse health outcomes that are not related to healthcare conditions, more social determinants, things like socioeconomic status and housing instability, things like that. And those kind of things will factor in as well for the community health population. And there's been a big push in the community health centers, for the community health centers to collect this kind of data. So that's months 1 through 4. We're hoping to retrain the algorithm based on the data we have available, and we'll probably need to go through some iterations before we get the right data there. And then the other piece we'll need to do is kind of making this, right now the SIFT model at Cedars-Sinai is run on a very expensive hypercompute environment that was very customized to their needs. It costs about $15,000 a month to run it right now, and Andrew Hudson is he's really, he's spent a lot of time customizing it to their needs, but it's an NVIDIA hypercompute environment, 1,000 terabytes of HIPAA-compliant storage, very expensive to run. But when talking to him about this project, he kind of said that this could be done in a much more economic fashion, much cheaper fashion on the Google Cloud. So we're hoping to run it in something closer to a $2,500 a month hypercompute environment that's HIPAA compliant, and he had much more specifics about that. So, and then over time, we hope to make it scalable so that other OCHIN members, other community health members can potentially use the model down the line as we build a consortium. And the goal is to hit a similar accuracy in the 80%, maybe 85% is what we'll shoot for initially, prior to deployment of their health system. So that's the first 4 months of the project. Months 5 through 10, we hope to take the model once we've tested it out and prospectively screen, almost like using our quality team, prospectively screen members at our 2 largest clinics in Santa Monica and Venice, and then go and and then based on their cluster of risk, reach out to them with various, various measures, connecting them to community resources, referring them to specialists, or getting them, other care they may need, or just even getting them in for a clinic visit if their score exceeded 75 or greater. We may need to fine-tune what that cutoff mark is based on the number of patients we screen. And over time, we'll kind of, do multiple cycles to get this better in a 5-month period, ideally. And then finally, in months 11 through 12, again, probably a pretty intense timeline. Share the model with other community clinics, starting in the Los Angeles area. Saban Community Clinic and Eisner Health are other community health centers with similar populations. One of them is on Ocean Epic. We hope to share the model with them, pilot it at their sites, gather more information, and eventually kind of take this model and spread it to health systems across the country that are on the Ocean Collaborative, and obviously beyond that after a certain point. And one thing we wanted to make clear with this is that we wanted to make sure that we validate their member populations to make sure the model fits before sharing the algorithm with them. And that was one of the requirements of the grant, to make sure that it's truly building a consortium where the algorithm fits the population that it's serving. So at 12 minutes. So that's kind of a high-level overview of what the project we're trying to do. And I'd appreciate any questions, comments, or even feedback as we go into the next phase of the project.
Do you anticipate this might have a negative effect because you have identified patients with high risk and insurance companies may say, we don't want to cover you?
That's a great question. I think for us in the community health center world, we have a member population and we're tasked with taking care of them regardless. So I think in different settings, in different healthcare settings, it may be a negative. And one thing is, yes, I think if this was used this kind of algorithm was used by insurance companies, it could definitely have a negative effect, which is why Andrew Hudson, my mentor and colleague, he wanted to use it for this purpose instead of that purpose. But it could have a negative effect, and that's a big reason why we want the people using the algorithm to validate it before they use the tool. So great question.
Do you have any plans to kind of investigate the patient perceptions of, if I get treatment at this specific clinic, I'm going to be entered into this pool where they're going to rate me whether or not I'm going to receive X, Y, Z treatment?
That's another good question. I think we're focusing more on a population health level, and I think it's more if they're kind of enrolled under us, we're treating it more like as though they're it's member outreach. I think the ethics behind individual patients consenting to this, I think it's a good question. I think we've approached it more at a pop health level, but that's something we should consider as we go to maybe phase 2 or 3 of the project, in terms of as we do enrollment for this and reach out to individual patients, maybe some sort of disclaimer or or discussion with, like, some sort of disclaimer to them might be a good idea as well. So that's a good thought. I'll file that away for when I get to that phase of the project.
Have you considered the technology acceptance aspect of it, or potential interruption or potential disruption in their workflow with this?
In terms of the patients or the healthcare providers?
Providers.
I think that's why I'm hoping to take it from more of like a quality team. So at our clinic we have practicing clinicians, we have different clinical staff who are doing care in the clinic. But there's a quality team who's looking at things at a more population health level, like whether we're meeting certain metrics, trying to screen out our highest risk members. So I'm hoping to kind of offload a lot of this onto them and maybe have a dedicated and part of the grant is getting funding for a team more dedicated to just doing surveillance on that level and trying not to impact clinical operations. So it's more an adjunct to clinical care, not so much adding extra onto the providers. So it's more on a quality pop health level.
Wonderful. Okay, so I think that's time for today. Thank you so much, Rohit, for your talk. And thank you to all of our speakers. Give you one more round of applause for all of your hard work.